callbacks get a biopsy. So now we're down to 15 biopsies. And of those 15 biopsies, on average, you find 3 cancers. So 3 out of 1,000 women would have breast cancer. 98% of those callbacks then are considered unnecessary to the woman. I mean, it has to be done if you have an abnormal finding, you have to work it up. But think of, for the woman's perspective, money, time, anxiety, waiting for the all clear, that's not insignificant. So that is a limitation of mammography. Now the dense breast limitation is very real because obviously mammogram is looking for microcalcifications. It's because of the architecture of cancer. As it grows, it's very disorganized. So you have abnormal calcium clusters that are in the blood vessels from the angiogenesis of the tumor. Well, a woman with dense breasts, her whole breast looks white, right? So that is why mammography is not very good. It has a 50% chance, up to 50% chance of missing cancer in a woman with dense breasts, which is why we offer ultrasound plus mammography to women with dense breasts. That's significant when you consider that 40% of the population of women have dense breasts. And it's even more significant when you look at the younger women with a family history or a genetic predisposition, because dense breasts are more common premenopausally. And if we're starting to screen these women in their 30s every 6 months, they're gonna have a lot of studies done. And with that high rate of false negative, you wonder if there's something better. Now, what about risk? So the risk implies the potential for harm, right? Not just that we don't know things about it. So the risks of mammography are radiation, because it's an X-ray, breast trauma, and overdiagnosis. So I want to dive into that a little bit. So to do a mammogram, you compress the breast between the 2 plates, right? And then you administer radiation. It's not a lot of radiation, but it is ionizing radiation. And it's really hard in the literature to get an exact amount of how much radiation is administered during a mammogram. What I found was about 0.4 millisieverts, but it varies from woman to woman based on the size and density of her breasts. So the other thing is that we are concerned with regard to ionizing radiation and cancer risk, that it could be a cumulative effect over the length of your life. So even though you wonder, right, okay, we don't want it, we're doing this to detect cancer, but radiation causes cancer, you know, what the heck, right? But the benefit, you know, the party line, the algorithm states that the benefits outweigh the risks. But there are studies that show and have calculated that there actually is a calculable risk of radiation-induced breast cancer. And the thought is, the study came out that calculated that for every 100,000 women screened, there are 88 radiation-induced cancers and 11 cancer deaths. So that number is not 0. I never knew that, and that bothers me, because I am a gynecologist, and I've given this to thousands of women. I trained in I was a military doctor for 8 years, so I could put all the studies, I knew all the algorithms, and yet I didn't know anything about potential risk. I'm not saying that women shouldn't have them, but should we not give them information and not shame them if they make an informed decision not to have one, given this information? Because when you think about, this is a little off tangent, but right, the doctors who are doing their best and they're in an organization where they take insurance and they're trying to care for a large number of women, and their companies, the insurance companies, give them extra bonuses if they're percentage of women that get mammogram, or actually it's not even a bonus, it's taken away from them if you don't meet a certain standard, that you're not a good doctor because 75% of your women aren't getting their mammograms. And so there's not that motivation really to say, make your own decision. It's like you're a bad doctor if your women aren't getting their mammograms. So this is actually more serious than what I just showed you, because we actually think that the radiation risk is higher than that. And the thing is, so this study came out in 2006, and so the previous data was based on calculations from atomic bomb survivors, which is very high energy gamma rays. Whereas a mammogram has lower energy X-ray, and they think that the possibility for DNA mutations from that, so more ionizing, is more, 4 to 6 times more. So let's look at those numbers. So instead of 88 induced cancers, now we're looking at 344 to 516. And instead of 11 cancer deaths, we're looking at 44 to 66 radiation-induced cancer deaths. Okay, well, let's carry that a step further. There's 48 million mammograms approximately each year in the United States. So, little math. If the risk is 1 out of 100,000, then that would be 480, right? But we're not talking about 1, we're talking about 88. So now that becomes the potential of 42,000 radiation-induced cancers a year. And that's on the lower end. If we multiply that by 4 to 6, it's significantly more. So we're looking at up to 31,000 radiation-induced cancer deaths because of our screening. Now, maybe the benefits do outweigh the risks. I'm not here to tell you that, but I'm here to say that I think it's important that we know the risks and that we give people this information and let them make their own decisions, right? I don't think in this room we do that, but I know that a lot of people are under pressure to do that. But I didn't know this until I started researching it. And when I really dove in, this information is out there, and it really, like I said, it made me kind of mad that I hadn't been told that in my training. Okay, so what about breast trauma? In order to do a mammogram, you compress the breast to about 1 centimeter in thickness. It requires about 45 pounds of pressure. There's certainly a risk of breast implant rupture. And there's numerous reports that talk about hematomas after just the mammogram, and some of them have required surgical intervention for drainage. Interestingly, when I was doing my research for this, prior to 1970, so in the 30s, 40s, 50s, in the textbooks and in the studies, trauma was listed as a risk factor for breast cancer. It's no longer listed as a risk factor for breast cancer. And I don't know if that's because we know more now or we're afraid to tell women that that's a risk for breast cancer. I don't know. It's just missing them. Now is the concept of overdiagnosis. Now, overdiagnosis is a risk of any screening thing, no matter what. Because the concept is that you could have cancer, but it's so slow growing that you can die at your God-given death age of whatever, 95. You will never have known that you had cancer. You will never have received any treatment. You're gonna live your whole life unaware, happy as can be, with a little tumor inside of you that nobody knows about. The problem is we don't know which tumors are those when we see cancer on a biopsy. And so anytime we see a cancer, of course we want to treat it, we want to do what we think is the right thing, but some of those cancers that we diagnose would never have caused problems for the woman. And yet the treatment does, right? So we're gonna do surgery, which has its risk. We're gonna do anesthesia, which has its risk. And if we're doing lumpectomy, we're definitely offering and encouraging radiation. And it's well known that chest radiation that goes along with breast cancer is a risk factor for heart disease. So there is an increased mortality from overdiagnosis. And we don't know when we see that which ones are going to be the slow growing or not, so we just treat them. No woman it's just unheard of. You wouldn't say, you have cancer, come back in a couple years and we'll see if it's bigger. No, it doesn't come that way. Okay, and lastly, anytime you do screening, it has to be acceptable to the population, right? Because you're going to screen large numbers of people in order to find things. Well, the CDC actually estimates that 30 to 40% of women in the United States opt out of mammogram screening who are at that age. That's a significant number. And of course, the reasons are various. Some of them it might be access to care. But as a gynecologist, I heard a lot of reasons, and they were fear of pain, fear of radiation, and the anxiety caused by what they considered to be unnecessary callbacks. And unnecessary to the woman meant that she was called back in, went through all these procedures, and then eventually was told she didn't have cancer. Okay, so there is a new technology that I want to introduce you to, and it's called QT imaging. This device, this technology, gives imaging of the breast. It has no radiation, no compression, no IV contrast. It's true 3D imaging, and it's FDA cleared. I'm going to tell you a little bit about it. The history is that there was grants given, and the goal was to develop a safe, more accurate imaging system to reduce the cost of medical imaging and to reduce the callbacks, because the FDA actually considers the callback rates with high false positives to be an adverse event. So once the machine was invented, they started performing lots of studies, starting in 2016. And in 2018, the machine was given FDA clearance as a breakthrough medical device. This technology is speed of sound through tissue, so transmission ultrasound, combined with the traditional reflection ultrasound. This is a picture of, it's color-coded, color change to show, but the speed of sound through tissue, different tissues transmit sound at a different rate. So there have been studies to validate, based on the speed of sound through the tissue, what they predict the histology to be with pretty good accuracy. It's amazing. So with reflection ultrasonography, right, so that's the traditional sonar, right? It hit the beam, hits the tissue, reflects off, and as it reflects off, it kind of scatters. So it's kind of like trying to see the size of the pebble and estimate the size of the pebble by the ripples afterwards, right? But with the transmission, you're measuring, the detection device is on the other side of the tissue, so the beam goes through the tissue, and then you're measuring, knowing the speed at the beginning and how fast it hits the receiver, what the speed of transmission is. And QT does both of them. On the right here, you see what the apparatus, imaging apparatus is, and then in the middle is the phantom breast. So on the far right, there's 3 transducers that are reflection, the traditional reflection ultrasound. And then on the 12 and 6 o'clock are the transmission mode receiver and the transmission mode transmitter. And this device rotates around the woman's breast while she lays on her belly. Her breast is immersed in a body temperature bath of water. One breast is imaged at a time, and each breast takes somewhere between about 8 and 18 minutes, depending on the size of the woman's breast. The speed of sound will show you the glandular tissue and the ducts, and the reflection ultrasonography is very good for the connective tissue. This is a pretty busy slide, but it's actually very fascinating. So there's some quotes out there talking about this imaging. Oh, it has 40 times the resolution of MRI, and I talked to the inventor, and I was like, you have to explain that to me, because that's a pretty bold claim. One of the amazing things is when you think of what we call now 3D mammography or 3D MRIs, they're not really 3D, they're approximations, right? So you have 2 millimeter gaps, and you're looking at planes of every 2 millimeters. They're getting images, and the gaps of 2 millimeters are computer generated. So there are gaps, and it's like when you're doing Photoshop and you're removing a blemish from the face, and the computer decides what color it's going to put there based on what's above and below it. That's what happens when the computer is filling in the gaps of these MRIs and the potential of the mammogram. Because of the way the arrays are oriented on this machine, there actually are no gaps, because they go out in different directions. And so it's true volumetric imaging. It has 36 billion data points per voxel, which is like the volume equivalent of a pixel. Whereas MRI has 180,000 data points. So 180,000 versus 36 billion data points. That's quite a lot as far as data points for calculating the images. This is not a breast, this is a pig kidney, but it's a really good illustration of the difference in clarity between MRI and the QT. So on the left, you can see all the way down, this is glomeruli. You can see that on the QT image, whereas this is the same tissue specimen. So on the right, you see the MRI version, and on the left, you see the QT version. Now, breasts are much harder to image than kidneys because, breast is, the tissue's changing all the time, hormone dependent. There's so different from woman to woman as far as fat content versus glandular versus connective tissue. So it's a much more difficult thing to image. But this picture shows you on an easier to image organ how much more clear the images are compared to MRI. This is a slide showing what, an H&E section from a complete mastectomy looks like, and of the QT image of that. And it can get really close to knowing and predicting what the actual histology is going to be. And here, this is the epithelial layer around the breast. It's only a few cell layers thick, and it's picked up on the image. This is a nice slide because this is the same breast of a woman with invasive ductal carcinoma. And on the left is the mammogram view. Next to that is the handheld ultrasound. The third image over is the MRI picture of the same breast, and then lastly, the QT image of the breast. So it's a really good picture of what the differences are and how clear you get the images.
Can you say the names of the technology?
Mammogram is XRM, handheld ultrasound, MRI, and the QT imaging. You're welcome. Okay, so why, if this has been FDA approved since 2018, has nobody heard of it? Right? I mean, it's not adopted by hospitals. No big radiology centers are offering it. There's a few machines around the country, but it's not yet well known. COVID, I think, is part of it, because nobody did anything for 2 years as far as advances, and everybody put their screening modalities on hold. But I don't think that's the whole answer. I'm sorry to say, I don't think that's the whole answer. When you look at the industry of breast cancer screening, it's an $8 billion a year industry. That's a cash cow. And then this was disturbing to me. 25% of hospitals are not owned by healthcare providers. They're owned by hedge funds who are not. If you're an investor, their loyalty is to the investors to make a profit and not to the healthcare system, unfortunately. And that number is increasing every day. So, is it one of those situations where we're following the money here? Why is there a resistance? I don't know. I don't think the doctors are resistant. I think, but somebody somewhere is not letting this show up. And it breaks my heart. So I think we're gonna change that, and I think in 10 years, maybe it will be available more, but that's a long time to wait. So, in conclusion today, I do believe that breast imaging and breast cancer screening is important. Even if it's, there's studies out of Canada that say that breast cancer screening is no better than a woman examining her own breast as far as length of life. But if we're looking at the ease of treatment, the lumpectomy versus mastectomy and things like that, I think that there's a big value in early detection. But I think we need to tell the women what we know and what we don't know, and quit just telling them to go get a mammogram without any explanation and shaming them if they don't get it, if they make a decision on their own not to get it. And I think we should quit penalizing doctors whose women have made that decision too, right? That's not fair. And then, with 30 to 40% of the women already in the country not getting screened because they hate their current options, maybe it's time to give them a different option. So I think that this potential modality, the QT imaging, has the potential to break some of those barriers, because there's no compression, there's no radiation, there's no heavy metal IV contrast, and you can see that the image quality is very good. So there's a couple websites here. If you're interested in more information, you can learn